presentation is on recent advancements in heart failure. We will be quick as time is short. So to introduce it briefly, heart failure is a complex clinical syndrome with signs and symptoms that results from any structural or functional impairment of ventricular filling or rejection of blood, which leads to decreased cardiac output. Heart failure remains one of the leading causes of morbidity and mortality worldwide, and guideline-directed medical therapy has evolved significantly recently. Emerging innovation have been seen both in pharmacotherapies and interventions recently. To understand the different drugs which are used in the management of heart failure, we need to understand, I know all of you are aware of the pathophysiology of heart failure. In heart failure, there is neurohormonal activation which leads to renin, angiotensin, aldosterone system activation, sympathetic nervous system activation, and natriuretic peptide production, which leads to cardiac remodeling and dysfunction, ultimately leads to hemodynamic consequences. And all these three contributes to disease progression. So in 2024 guidelines by American Heart Association, they emphasize on early diagnosis and risk stratification of heart failure patient. Comprehensive guideline-directed medical therapy for heart failure patient is the key of management, and they also emphasize personalized medicine approach for the management of this patient. The 4 drugs are pillars of guideline-directed medical therapy recently is ARNI, which is angiotensin receptor, neprilysin inhibitor, beta blocker, MRAs, and selective glucose reuptake inhibitor. This beta blocker and MRAs are in practice since long, but recently, in last few years, this ARNI and selective glucose reuptake inhibitors have been added in the management of heart failure. So the first drug is ARNI, which is sacubitril/valsartan combination. It combines, this drug is a combination of angiotensin receptor blocker, that is valsartan, with neprilysin inhibitor, that is sacubitril, and it reduces neurohormonal activation, which decrease vasoconstriction and enhance natriuretic peptide production. This drug have been studied in Paradigm heart failure trial, which compared the combination of this drug to ACE in heart failure patient with reduced ejection fraction. And this trial showed 20% reduction in cardiovascular death and heart failure hospitalization. So it demonstrated superior mortality benefit over ACE, leading to its recommendation as first-line therapy over ACE or ARB. Other trials on ARNI are Paragon heart failure trial, Pioneer heart failure trial, and Prove heart failure trial. The beta blocker, what does it do? It reduces sympathetic nervous system activation, myocardial oxygen demand, and ventricular remodeling. And the trials which suggest its indication in heart failure patient are Merit heart failure trial, CIBIS 2 trial, and Copernicus trial. The third drug is mineralocorticoid receptor antagonist. It blocks aldosterone, so reduce fibrosis, sodium and salt retention, potassium loss, and so prevent worsening of heart failure and mortality. And the trial which shows the importance or the benefit of this drug in heart failure patient is RAILS, which showed 30% reduction in mortality with spironolactone in severe heart failure patient. And the other trial was Emphasis heart failure trial, which was conducted in 2011. Then the selective glucose uptake inhibitor, that is dapagliflozin, it was originally for diabetes patient, but it also reduced heart failure patient hospitalization and cardiovascular mortality by promoting natriuresis, reducing preload and afterload, and improving myocardial metabolism. And the trials which shows the importance or significance or benefit of this drug was a DEPA heart failure trial, which was conducted in 2019, Imperial reduced trial, Imperial preserved trial, and liver trial. The additional pharmacological therapies are added according to the symptoms of the patient, which is ivabradine, hydrelazine, diuretics, vericiguat, and mecarbil, omectin mecarbil. Vericiguat is a new drug. It's a soluble guanylate cyclase stimulator, and it is indicated in heart failure patients with reduced ejection fraction with recent decompensation despite guideline-directed medical therapy. It actually enhances nitric oxide signaling, so improves vasodilation and myocardial function, and its benefit have been demonstrated in Victoria trial. The second is omectin bicarbal. It is a cardiac myosin activator, and it is also indicated in heart failure patient with reduced ejection fraction. It actually increases cardiac contractility without increasing oxygen demand and intracellular calcium, and it improves systolic function. Clinical benefit have been demonstrated in galactic heart failure trial. Ivabradine is indicated in heart failure patients who have a heart rate of more than 70 despite maximum dose of beta blocker, and SHIFT trial showed a reduction in heart failure hospitalization with this drug. Hydralazine and isosorbide dinitrate, it's for African American patients are those who are intolerant to MRAs. A HEF trial was conducted which shows improved survival in self-identified African American patients. Diuretics, it's always for symptomatic relief, and it have got no mortality benefit. Dose trial compared IV diuretic strategies in acute heart failure but found no significant mortality benefit. Device therapy in heart failure, we all are aware about intracardiac defibrillator, cardiac resynchronization therapy, left ventricular assisted device, but currently baroreceptor activation therapy is in practice, and it is indicated in advanced heart failure, especially with autonomic imbalance. It modulates sympathetic overactivity, improves symptoms, and anti-pro-BNP level. Another device is CardioMEMS. It's a wireless pulmonary artery pressure monitoring system, and it actually reduces hospitalization by guiding therapy based on hemodynamic trends of the patient. Then transcatheter mitral or tricuspid valve repair devices, that is MitraClip or TriClip. It's for second-wave functional MR/TR in heart failure patient. And COPE trial was conducted, which shows improved symptoms and reduced hospitalization in these patients. Then some biomarkers recently added in heart failure patient for the diagnosis and predicting prognosis. One is soluble ST2, which is a member of interleukin-1 receptor family. It is released in response to myocardial stress and fibrosis, and it reflects cardiac remodeling and inflammation independent of hemodynamic stress of the patient, and it's a prognostic marker. Higher levels means worse prognosis. Advantage of this marker is it is not affected by the patient age, BMI, or renal function, unlike of natriuretic peptide. The second biomarker is galactin-3, which is a beta-galactoside binding lectin produced by activated macrophages, and it is involved in fibrosis, inflammation, and ventricular remodeling. It actually predicts adverse remodeling and the mortality in heart failure patient, and it is limited by, limitations are affected by worsening in renal function and less dynamic than natriuretic peptide in acute settings. Then the gene and stem cell therapies, these are experimental or under investigation. The aim of gene or stem cell therapy is to regenerate myocardial tissue and improve contractility of the heart, and it's still under research, not yet in over routine clinical practice. So to conclude my presentation, the future of heart failure management is shifting more towards personalized, regenerative, and normal pharmacotherapies. The precision medicine enhance individual response to heart failure treatment. Regenerative therapies hold promise for reversing myocardial damage, and innovative drug classes are expanding treatment options, particularly in heart failure with preserved ejection fraction or advanced heart failure with reduced ejection fraction. So with ongoing trials, the next decade promises groundbreaking advancements in heart failure care, aiming for better survival, reduced hospitalization, and improved quality of life. Thank you.